Record. Okay, so we are going to talk about modes of transmission today.
And Papa has one. Yeah.
That little one's cute.
There's homework.
Okay. Make sure we mute. Never find the mute all. Let's see. Okay. So modes of transmission. So we're going to talk about how these microorganisms that we've been learning about, how they're spread to our patients, how we can prevent the spread to ourselves while we are practicing in the hospital, and prevent spreading them to other patients. So the chain of infection. So what is needed for an infection to occur is an agent. So that's the microorganism. A host. So that's who becomes infected or what becomes infected. And then the proper environment that that microorganism needs to live. So that would be an aerobic environment if the microorganism thrives in oxygen. Anaerobic, that is what I'm talking about. So the chain of infection, and we'll go through each of these parts of the chain as we go through the lecture. So transmission occurs when the agent leaves the reservoir or the host. So it leaves one area that it's kind of sitting dormant or latent in, and then goes through an exit through a mode of transmission. So respiratory droplets, for example, would be a mode of transmission, or picking it up off a hard surface and somebody gets it on their skin and touches their face. That would be another example. And then through a portal of entry. So if we touch an escalator handle and then we rub our nose, the portal of entry would be, excuse me, the nasal passages. And that's when the microorganism can infect a susceptible host. So a susceptible host may be someone maybe who's immunocompromised or very young, very old. So maybe it's a newborn baby and their grandma is carrying RSV, or a brother or sister is carrying RSV, which doesn't infect that person because they have a stronger immune system. But kissing that baby would make that baby more of a susceptible host because they don't have that built up immune system. So this is just another visual of the chain of infection, and we will go over each of these areas. So you have the infectious agent, which would be the microorganism, and then the reservoir, so where they're living, how they exit that reservoir, so the portal of exit, how the microorganism is transmitted, the portal of entry, so how it gets into the person that becomes infected, and then what makes a susceptible host. So the reservoir is the habitat which this microorganism lives in, and where it normally grows. So soil could be a reservoir for fungus, for bacteria, for any spores that grow. And that's where it lives, it grows, and then it multiplies. It can be human. It can be, so we'll talk about carriers. It can be an animal. So if an animal is infected with rabies, they can pass that and transfer that to other animals and humans. Or it could be the environment. So water, soil, in the air, wherever that microorganism is going to thrive. So the reservoir may not be the source from which an agent is transferred to a host. So, excuse me, so if someone is digging in their garden and moving soil around, the reservoir is going to be the soil, but just touching that soil and planting may not infect somebody. It could be if you're digging and you're tilling or you're mowing and it gets aerosolized into the air and then they breathe it in. that may be how it's transferred. If I ever go too fast, just tell me to slow down. I kind of watch you guys see if you're done writing, so that's why there's some long pauses. Okay, so we can be reservoirs, and that's going to cause when we transmit diseases or microorganisms from person to person without intermediaries. So we can transfer through mucous membranes. So if we sneeze, cough, talking through respiratory droplets, sexually transmitted disease would be, there's nothing in between that needs to happen between transmission. Now we could still transfer from person to person with an intermediary. So if someone goes to the bathroom and they are carrying a microorganism and they don't wash their hands and they touch something, and then somebody else comes behind them and grabs the door handle to a bathroom, and then they become sick. Or preparing food after not washing your hands. Human reservoirs can be symptomatic or asymptomatic. And we'll talk more about carriers in a little bit. So asymptomatic or passive or healthy carriers are going to be carriers of a microorganism. Strep is a common one. They are not showing signs and symptoms, so they're going to pass it to other people who can become symptomatic and have an infection. Incubatory carriers can transmit an agent during the incubation period. So this is before they become symptomatic. So a big one is COVID. So people who are will be asymptomatic because COVID hasn't started their infection process yet. They're in the process of the virus injects, remember it's RNA or DNA into the host. And then as those cells multiply, that's when we start to have the infection. So COVID can be transferred from patient to patient or person to person during that incubatory time. So we can still become infected even though that person doesn't have any symptoms. So there are two types of carriers. We have the convalescent carrier who has recovered from their illness. So they've gotten strep throat, or a kiddo has gotten RSV or whooping cough, and they become better. They've recovered from their illness, but they're still able to transfer. And then you have chronic carriers. So these are people who harbor that microorganism, Hep B, strep throat, typhoid fever is another one. And these people may never have symptoms. They may never have an active infection. So that, excuse me, that microorganism is kind of dormant, staying latent, but they can still give it to other people who have the signs and symptoms of the infection and become very sick from it. So this picture is just a little infographic of how reservoirs work. So reservoirs can be human. So this is referring to these carriers here. It can be animals, or it can be the environment. And then modes of transmission, which we will go over each of these. Direct contact, droplet, so sneezing, coughing, even breathing sometimes. If we're too close to somebody, we can inhale those pathogens and become sick. A vector, so mosquitoes, ticks, those are examples of vectors. A vehicle, so uncleaned food. So if someone isn't washing their hands and then preparing food, or food is not cooked properly, it becomes a vehicle. And then airborne, so these microorganisms are very small. So Legionella would be an example of an airborne through an air conditioning system, or a swimming pool, hot tubs. And then that is how the host is infected. So they can breathe it in. It can be injected, so like a blood transfusion, catheters, which we will talk about, direct contact. Animal reservoirs. So these diseases are transmitted from animal to animal, and sometimes animal to humans as well. So zoonosis is the term when an infectious disease is transmitted from vertebrate animals to humans. So coronaviruses, remember we talked about last week that there's more than one strain of coronavirus, are zoonotic. So that means they can be transmitted from animals to people. And they're doing more research on how this is possible and what causes the mutation in these viruses to allow it to be transmitted from animals to human. And MERS, which is the Middle East Respiratory Syndrome, came from cats to human. And it can also be camels to humans as well. There are some coronaviruses that are found currently in only animals, but have not yet infected humans. So that's where they're doing their research to see what causes that mutation. So we talked about animal reservoirs, environmental reservoirs, so soil, especially fungal agents, and different soils across the country, across the world are going to harbor different agents that are going to be able to be transferred. So mushrooms are a big one. And it's not necessarily the mushroom itself or the fungus itself, it's going to be those spores. Water, so Legionella is a big one in water. And it doesn't matter necessarily if the water is brackish and muddy and just looks nasty. It can be normal water. So there was an outbreak, I think 5 or 6 years ago in Glenwood Springs of Pseudomonas. So Pseudomonas likes the water as well. And just breathing in the air that comes up off of the water can cause the infection. We can also ingest water. So if we ingest water that's affected, that can also cause an infection. So some modes of transmission, we have direct and indirect. So direct is going to be physically touching or physically spread through cough, sneeze, talking. So if we had an accident or somebody was swimming in an area that had lots of algae and they had an open wound, that would be an example of direct transmission. Sexually transmitted diseases would be direct transmission because of the contact between mucous membranes. Indirect would be airborne. So through ventilation systems, breathing in particles or spores that were mixed up in soil and then released into the atmosphere. So vehicle-borne, so water, food, and air. So that would be when we say we got food poisoning from food that wasn't cooked properly, that would be an example of indirect. And then vector-borne, so animals or blood-feeding arthropods like mosquitoes and ticks. So vehicle, water, food, air, vector, animals. So to go further into direct transmission, direct contact, so skin to skin, kissing or sexual intercourse. It can also be direct contact with infected soil. Wrestling mats is another example. So that would be skin contact with the mats. Remember, tinea or ringworm can be caused with direct contact. Sometimes you'll find preschools or daycares have an outbreak of ringworm because the kids are playing together, and if their skin has an infection and they're touching another kid's skin, that would be direct contact, or playing with toys or on the playground and then touching their skin, they can get ringworm that way as well. And then droplet spread, which is where we are going to see as RTs the most infections. So that's a spray of relatively large or short range aerosols. So for those of you who have kids or who have worked with kids or been around kids, you know, it's lovely when they sneeze right in your face. That would be an example of droplet spread. Something as RTs that you need to be mindful of is when you're working with patients in the ICU and you have them on a mechanical ventilator and you need to break what's called the circuit. So that's the tubing that goes from the ventilator to the patient's airway. And you have to break it, so you have to take them off the ventilator. If the ventilator is not paused or shut down, be careful on where you place the end of that circuit, because you don't want to accidentally spray yourself in the face or spray somebody else in the face, because all that droplet and aerosol is going to be in that tubing that comes directly from their lungs. So depending on the microorganism and the size of the microorganism, and we'll talk about some different precautions where the droplets are bigger, they're not going to stay in the air as long, and they're not going to be able to travel as far in the air, whereas there are some that are even smaller, so they can travel farther in the air. So some can transmit just a few feet away, some can transmit farther away. So indirect transmission. So this would be an infectious agent that comes from its reservoir to a host suspended by air particles or by another vehicle. So airborne, we were talking about those evaporated droplets in the air for a long time. Tuberculosis is considered airborne. We'll get to those precautions. Chickenpox can travel farther than, say, the flu or Pseudomonas. Those are going to be bigger droplets, which will evaporate faster. Vehicles, so food, water, biological products like blood, so a blood transfusion, and fomites, which are going to be something that is considered like a carrier of a disease. And then we have vectors, so mosquitoes, fleas, ticks, worms may also carry an infectious agent. So anything mechanical. So it's not coming, you're not coming into contact or directly inhaling. Something else has to carry that disease to you. So West Nile virus, malaria, African sleeping sickness, those are carried by vectors because they're carried by mosquitoes or insects. So we need to have a portal of entry. So a portal of entry is how this microorganism gets into the person themselves. So we've gone from the reservoir where they live to how it is going to be transmitted to and get to the susceptible host. And then it has to get into the body. So that is our portal of entry. So a big one that we need to be worried about as respiratory therapists are our patients' catheters. So we can have Foley catheters, which are urinary catheters that are placed by nurses. Arterial lines, so this is a picture here of an arterial line through the wrist. And anytime we have a line, a tube, or a drain, anything that's foreign to the body that we place into the patient, we have a higher risk of infection. So we always want to make sure that we're looking at the site, looking for redness, swelling. Is it warm to the touch? Is it painful? And then we're going to look for signs and symptoms of infection, like increased fever, cough, their color of their skin, are they hypoxic? Those are all going to be signs and symptoms. So a big one, another big one that RTs have to worry about is when we place an endotracheal tubes and we put them on a mechanical ventilator. We're putting a tube down their throat and into their lungs. So we want to make sure that we're doing proper oral care. So we're cleaning out their mouth so that we clean that bacteria and it doesn't fall down into their lungs and cause a pneumonia. So anything invasive, we want to make sure that we're properly cleaning. We're checking for signs and symptoms to make sure that they're not compromised. So the host, the final link to the chain is a susceptible host. So those who are at a higher risk of infection are patients on chemotherapy who we've knocked out their immune system because we're treating a illness. Those who have a chronic disease that make them more susceptible to infection. So cystic fibrosis, COPD, patients who have diabetes are more likely to get sick. And then it varies by age as well. So the very young and the very old are more susceptible. Individuals' genetic makeup can increase or decrease susceptibility. So you hear about those people who are never sick, they never get sick at all. They just have really good genes. And then there's people who are more likely to become sick because of their genetic makeup. Also, patients who have had a disease before, so they get sick easier. So I had tonsillitis when I was a little kid, and I would get strep throat all the time because my tonsils swelled up and then they didn't ever go back to their normal size. So the tonsils' job is to catch pathogens to prevent them from going into the lungs, but then that leads to strep throat. So they can have more infections. So your body can alter itself if it has any physical changes, and it can make them more susceptible. We can have specific immunity to protective antibodies that are directed against a specific agent. So getting vaccines. So if we're all current on our vaccines, we're going to have these immunities that are specific. The flu shot, that's why you get it every year. COVID vaccine, MMR, that would be examples of specific immunities. And then there are non-specific immunities or innate immunities. And so this is the immune system that you're born with. So it's not specific to one pathogen. Your immune system is going to fight off anything that is foreign, that does not belong in the body. Another interesting genetic makeup that can increase or decrease susceptibility is I've never had the chickenpox, even though I've been exposed. Same with my sister. And going to doctors, they think we just have a natural specific immunity. So it's very interesting how the body works.
I was gonna say, so I'm the same way, and I've had doctors tell me I have a mimicking immune system where I'll show signs of it, but I never get it.
That's interesting. I haven't heard that term. I'm gonna have to look that up. Mimicking immunity. And then, so I did, when I was in respiratory school, have to get the varicella immunization. And when I got my first job, which was maybe a year and a half after my last booster for varicella, I had no immunities to it in my body, which was weird. I had to get the booster and get the immunization again. That's crazy. The body is very interesting. So we're going to talk about breaking the chain of infection. You think hospitals are very clean and it should be safe and there shouldn't be pathogens, but the hospital has, no matter how much we clean, we need to take the proper precautions to protect ourselves and protect our patients. There's all different kinds of bugs that come in and out of the hospital. So when we were talking about the infection agents itself, we want to get a quick diagnosis so that we can treat it faster. When it says antimicrobial stewardship, we need to educate ourselves and our patients about proper hand hygiene, how to prevent the spread of bacteria, viruses, and fungi, where they're found, so we can prevent it. So prevention is going to be a huge part of breaking the chain of infection. At the reservoir level, we want to clean and disinfect properly. So that is going to be knowing the equipment and the chemicals that you use in your hospital. So in the respiratory department, we want to make sure that we are cleaning our tools properly. So we have glide scopes or intubation equipment. You need to make sure that you know how to properly clean them. Bronchoscopes, properly disposing and not exposing yourself to ventilator circuits, and taking the proper precautions when you're doing aerosolized treatments. And then our portal of exit, so we want to keep open wounds and we want to protect skin, making sure that we properly clean up body fluids. So blood, you need to clean with hydrogen peroxide or bleach. That will kill any of the bacteria, viruses in blood. Whereas you have what's called CAVI wipes, which are bactericidal and virucidal for urine, sputum, feces, you would use those. So know that blood is cleaned up with bleach. Portal of exit, so if we scratch ourselves, we want to make sure that we are doing proper hand hygiene so we protect ourselves and not have it become a portal of entry, but we also don't want to have it a portal of exit either. That's why when you do an arterial blood gas or you are puncturing the skin for anything, make sure you're wearing the proper gloves and PPE. Mode of transmission, so hand hygiene is going to be a huge part of breaking the chain of infection. You can see it's part of portal of exit, mode of transmission, and portal of entry. And it's not just your hand hygiene. Education is going to be a huge part of being an RT and educating your patients on proper hand hygiene so they can protect themselves. When they're at home, they can protect their loved ones and others. Personal protective equipment or PPE. Food safety. We want to make sure we're cleaning and disinfecting. And then isolation when necessary. So if somebody is suspected to have tuberculosis, we're going to put them on isolation protocols. And it may result in them not being able to have visitors until it's either ruled out or treatment is started. Then we have portal of entry. So again, protecting broken skin and incisions. So if you cut yourself while you're in the hospital, it happens. Always making sure you wear your gloves and keep it wrapped up. We're looking at catheters and tubes for signs and symptoms of infection. We're making sure we're doing oral care and cleaning the site. Nursing is responsible for like dressing changes on wounds and lines. So even if you're not taking care of the IV, that's not in our scope of practice, is looking at the IV, but we are going to do a head-to-toe assessment of our patient when we check on them. So if we notice that their IV looks swollen or it doesn't look the same as the last time you saw a patient, just letting the nurse know, and then she can take care of it, maybe change the IV. They may have to get a swab to see if there's an infection going on. We want to stop it as soon as possible. And then breaking the chain. So this is, we're going to get our immunizations to protect ourselves and to also prevent the spread of diseases. We're going to treat our underlying diseases as soon as we can. Getting health insurance that would be preventing a susceptible host, because we are going to make sure that we're healthy enough and our immune system can fight off any of these microorganisms. And then patient education. So education, like I said, is a huge part of our job. We want to make sure that we educate our patients on who is more at risk, what puts you at risk to see microorganisms. If you're working with specific patient populations like asthma, and they have what's called a scratch test or an allergy test, and they find out they're allergic to mold or weeds, educating them on how to stay away from those organisms so they don't develop a pneumonia due to Aspergillus or another trigger. So we want to try and control or eliminate the source of transmission as much as we can. So if we have a bacterial infection, antibiotics are going to help control and eliminate the transmission of that bacteria from one to another. Decontamination of soil. And then asymptomatic patients can still be treated so that they can't spread it to others. So if they get a test and it comes back positive, they will still be treated even though they do not have symptoms. And then we want to prevent directed modes of transmission. So isolating someone with an infection. So quarantining somebody who's had an exposure to COVID-19 or a positive test for COVID-19. In the hospital, we are going to isolate our patients who either are suspected of TB or have TB or varicella, the chickenpox. Those are what's called airborne precautions. So they're going to be put in a room that has a negative pressure. So pretty much all the air is being sucked out of that room to help prevent those aerosol airborne droplets from being suspended in the air. And then we'd want to talk to those patients on discharge about how to safely be around others in the home to prevent the spread from them to family members or friends. Bug spray is going to be another way that we can intervene to help prevent West Nile virus, malaria, depending on what area of the world you were in, to prevent those vehicle-borne transmissions. And that's why you treat your dog for flea and ticks and prevent them from getting sick. So we need to protect our portals of entry. So PPE, this hands down is going to be one of the single most important things you can do for yourself. So what comes to mind with PPE? How can we protect ourselves in the hospital?
Like gloves, masks, goggles.
Gloves, masks, goggles, those are the big one. I'm a huge advocate for wearing some sort of eye protection, even if it's just your glasses. I always wear my glasses in the hospital, even if I was not doing an intubation or something with aerosol, because you take your glasses off when you leave the hospital and you look at them and there's all kinds of specks on them, and you want to protect yourself. So in areas where there's high mosquitoes, nets can be a form of PPE. Wash your hands. So even if you're not washing with soap and water before and after you go into every room, foaming in and out. So using that alcohol foam It protects you and it protects your patients as well. So universal precautions. So this is going to be what you do with every patient. Hand washing or foaming in and out. Always wear gloves when you handle patients' body fluids. I always wear gloves. Most people always wear gloves. It's just good practice, even when you just walk into a room, because you're going to touch more in their room than you think. You're not just going to stand and talk to them, even touching the bed or the counter or grabbing something for them. It's just better to be safe than sorry. When you go out to clinicals, you'll see that every RT is different. And some RTs are saying, oh, I'm just giving a nebulizer treatment. I'm not going to put on gloves because I'm not touching body fluids, but you're touching the flow meter or the oxygen on the wall. You're touching their nebulizer cup. You may not realize that you touched a chair or their bed rail. So gloves are going to be great protection for you. A mask, face shield, and goggles if you're at spray risk. So when you learn how to do intubation and you're intubating a patient, we're going to be right by their nose and their mouth. We are worried about vomit. We're worried about sputum. We're worried about respiratory particles. So you want to make sure you have a mask. A gown is good for spray risk. So some are plastic, some are cloth, some are paper. When you go into a code blue and it's a trauma and they have open wounds, you don't want to get their blood on you. So a gown would be good there. If you're doing a bronchoscopy, it's better safe than sorry. And then you're going to discard single-use equipment. So you're always going to discard your gloves. And depending on your gown, some hospitals have cloth gowns, especially after COVID and the PPE shortage. So discard your single-use equipment, and then they'd have a separate bin for your gowns if they go to the laundry. Always be careful when handling sharps. Never, never, never recap a needle. You put yourself at a greater risk for sticking yourself with a dirty needle. And if you do that, then you're going to have to go down to occupational health and to the ER, and they're going to have to follow their hospital's protocol on workman's comp. And if you do it as a student, there are a few steps that we have to take as well through our liability insurance for you guys. Do not do mouth-to-mouth in the hospital. Absolutely not. There's going to, when we go through BLS, you will learn how to use the bag, the AMBU bag with a mask to provide respirations during CPR. I don't recommend using a pocket mask in the hospital. We're just going to focus on compressions. So never do mouth-to-mouth in the hospital. I also recommend not doing mouth-to-mouth outside of the hospital unless it's maybe a loved one that you know.
Stacy, do you recommend like an extra set of scrubs in extreme cases, or is that overkill?
You can carry, I would carry one in my trunk of my car just because you never know what's going to happen. But there's also OR scrubs that you could change into if you got a ridiculous amount of stuff on you. That's a good question. I also would carry during the winter time, I'd also carry extra scrubs and change of clothes in case I got snowed in at the hospital. So it was just something else I would carry with me in my car. And if you need to change your scrubs and you're a student, don't be afraid. Your preceptor should be able to help you with that, whether it's getting OR scrubs or if you have scrubs with you. Just letting them know, hey, I got pee on me, I got urine on me, or I got a bunch of sputum down me. Is it all right if I go change? And they'll let you go change. We've all been there. Another thing, just this is totally random. When you do CPR, make sure they don't have any colostomy bags. I had a coworker once who went to do compressions and he didn't notice the colostomy bag and it came undone. And so he had to change his scrubs because he got poop all over him. also another one. If depending on what type of shoes you wear, boots are good. I used to like wearing Keens because they cover your foot, they're comfortable. But tennis shoes that have mostly fabric on them, you're going to get body fluids that can leak through them and leak into your shoes. So just keep that in mind. Danskos are good. They're a little pricey, but they're not going to let body fluid leak in. I've seen people wear Crocs with the holes in them. That's another entry point for body fluid. And then you're walking in somebody else's body fluids all night. Okay, so isolation. So isolation is going to help protect other patients and other people who do not have the microorganism infection. So we need to protect ourselves differently for different diseases. So when we go into an isolation room in the hospital, there's going to be different type of isolations. So they are contact, droplet, airborne, and neutropenic, or reverse isolation. And we will talk about each of these. So contact isolation, we're going to need to wear gloves, gowns, masks are optional, but diseases for contact isolation are MRSA, methicillin resistant Staph aureus, bursa, vancomycin resistant Staph aureus, and VRE, which is vancomycin resistant, I want to say E. coli. But these are all very highly resistant drugs that are hard to treat. So we want to stop the spread. We don't want an outbreak in the hospital, which is possible. Think about all the patients that we see, especially as RTs. Nurses have, depending on where they're at in the hospital, in the ICU, they have 1 to 2 patients. On the floors, they have hopefully 6 to 7 patients at the very most. So they are going to see less patients. As RTs, we can see 20 patients a day or more, depending. So we're going into a lot of different rooms. So these microorganisms can hitchhike a ride on our scrubs, and we may never even know it, on the bottom of our shoes, on our stethoscopes. So between patients, it's going to be imperative that you wipe down your stethoscope with an alcohol swab so that you're not listening to Mr. Smith's breath sounds and he has MRSA and you don't know it yet because he's not on isolation, and then you go listen to Mrs. Jones and then you've taken it from him to her unknowingly. So in contact isolation, along with gown and gloves, they should also have disposable equipment. So that would be a disposable stethoscope. They'd have their own like pulse ox in their room that you would be able to use or wipe down in between. But when somebody comes into the hospital and they don't have a known infection yet, there may be a day or two that they are not on precautions because they haven't got those results back yet. So still cleaning the stethoscope, even though they're not on precautions in between patients, is necessary. If you are at a hospital where you're using your own pulse ox, wiping it down with alcohol in between as well. So enteric contact isolation is the same as contact, but with regular contact isolation, you can use the hand foam to foam in and out. But with enteric contact isolation, you must wash your hands with soap and water. That's because of C. difficile, Colostrum difficile, is an infection in the GI tract, and it causes diarrhea, and it's a terrible, terrible smelling microorganism. And once you get out there and you treat somebody with C. diff, you'll understand what I'm talking about. It's just this, it has its own smell. But alcohol does not kill the spores. You have to use soap and water. That soap is going to emulsify the cell wall and kill the bacteria. So you still need a gown and a glove and gloves, but you would use soap and water to wash your hands. And this is an example of what you might see on the door. You'll see a big stop sign and it'll tell you what type of precautions it is, and then what you need to enter the room as a practitioner. Some places have what visitors need as well, which would be the instructions to wash your hands with soap and water every time you leave the room. And then outside of the room, when special precautions are required, they're going to have a little cart, and every hospital looks a little bit different, that contains gloves and a gown, any disposable equipment that is needed, so that you can gown up and put your gloves on before you enter the room. And then after you're done treating the patient, you'll take everything off and throw it away in the room, and then wash your hands. Next is droplet precaution. So with this one, we're going to need gloves and a basic surgical mask. So a basic surgical mask. So this is going to be a lot more common during respiratory season, which is September, October-ish, all the way through April, because we are going to be busy with the flu, meningococcal meningitis, the mumps and rubella, diphtheria, pertussis, which is whooping cough. So remember MMR. So this has one immunization. Diphtheria and pertussis are covered under the Tdap. So these ones are not going to be as common, just because most people are vaccinated, except for little ones. So you'll see whooping cough in little babies who are not old enough to get the vaccine yet. Influenza is going to be what we see the most with droplet. And then infections that are caused by multi-drug resistant streptococcus. So during respiratory season, pediatric hospitals are a lot busier than adult hospitals. Typically their respiratory season lasts longer just because there's so many little ones who aren't old enough to be immunized yet.
Yeah, I was going to ask, do you see a lot of mumps and rubella still?
No, there's more isolated outbreaks. I know last year or the year before, there were measles outbreaks because somebody had come to visit family and they were not vaccinated and they passed the measles around, and they ended up at Children's Hospital. There were quite a few cases. It's also going to depend on socioeconomic areas. Some people don't have access to healthcare to get these immunizations or have the education that they need. So that's when public health comes into play to help educate these specific patient populations. So airborne is another type of precautions. So in airborne, we talked a little bit about it earlier. So tuberculosis, varicella, the measles are all going to be airborne. We still need gloves, gown, but for the mask here, we need an N95 mask. So that's what's been talking a lot about around COVID. N95 masks have been really hard to come by with that PPE shortage. A lot of people, and you will be able to get a half face respirator, and we provide the filters for you guys, and it acts like an N95 mask, and it's going to prevent these smaller particles from being able to be inhaled. So the surgical mask is not, the weaving isn't as tight in the material, So it catches the big aerosol droplets and prevents them from being inhaled, but smaller microorganisms like tuberculosis, measles, and chickenpox can get through them. So that's why the N95 is required. They will also go in that negative pressure room. So all their air is being sucked out through HEPA filters and filtrated through the hospital before it is reintroduced into the hospital circulation. Sometimes we'll have patients on airborne precautions if they are in a negative pressure room because they are on aerosolized meds that are very caustic to caregivers, like somebody who has RSV and they're on what's called a SPAG. It's a virostatic medication, but it's very toxic to caregivers. So we'll put them in a negative pressure room so that we're not exposed to that drug. So we want to increase the host defense. So vaccinations are important, the education of why vaccines are important, and then making vaccines available to the general population. And then prophylactic drugs as well. An example of this would be, so with Maryland cystic fibrosis, she's on azithromycin 3 times a week because she needs to prophylactically get rid of those bacteria that may cause an infection. So herd immunity is when interventions attempt to prevent a pathogen from encountering a susceptible host. And so if high enough people, a number of people are resistant to an agent, that it's going to be, we're going to protect those who are not. So we want to become resistant to those microorganisms to protect those who cannot protect themselves. So the immunocompromised, the very old, the very young. So, and that's why immunizations, we have to have large numbers of immunizations because we are protecting those who cannot get the immunizations or who are going to be more susceptible even if they have been vaccinated. So how to wash your hands. When we are on campus for Therapeutics 2, we'll do our hand washing check off. So you should use warm or cold water because hot water is more likely to damage the skin, create an open area for bacteria or other microorganisms to use it as a portal of entry. So warm or cold water. Lather your hands with soap because the chemicals in the soap are going to help emulsify those microorganisms, even if it's with warm or cold water. And you want to get your hands from the tip of your fingers underneath your nails all the way up to past your wrist. Make sure that you're getting in between your fingers, under your fingernails. You should take off any jewelry that you have on. When you're in the hospital, you should not wear nail polish, fake nails. That's a great place for bacteria to harbor. You should not have long nails. They should be pretty short because microorganisms can grow underneath your nails. And then we unknowingly transfer microorganisms to ourselves and to other patients. And when you're at clinicals, when you're on campus, it's school policy and part of the dress code that you don't have fake nails. So before you come to campus, if you have them, make sure you take them off. And then you're going to rinse all of the soap, grab your paper towel, and turn the faucet off with that, because if you don't, you're grabbing the handle that you grabbed with dirty hands prior to washing them. And then always open the door with paper towel. So when we process equipment, we are going to use wipes, chemicals, and machines. And in these chemicals, we're going to use bacteriostatic, bactericidal, virucidal, sporicidal, and we are going to disinfect or sterilize. So disinfect would be cleaning with those wipes and wiping down equipment. Sterilization, we are going to send equipment out to sterile processing, and they are going to add heat and chemicals to sterilize and kill all of those spores and microorganisms.
It's kind of like an autoclave, correct?
Yeah, it's like an
Sterilization?
autoclave. Yep.
Okay.
So they add pressure and heat and chemicals to do so. Every hospital is going to have a different process for respiratory equipment. So for our hospital, when we did bronchoscopes, we had either like a cleaning solution that we would use, or we had a machine called the Steris, and that would run chemicals through the bronchoscope to kill all of the microorganisms that were on that machine. And I feel like half the time it would break down. So we would use the chemicals, and you'll have logs that you have to write on. You have to keep track of the temperature because it has to maintain a stable temperature. If you ever forget what the temperature is, what the steps are, your hospital will have books, like little binders, where you can read step by step what you need to, how you need to process it, what you need to log. And then if you have accrediting agencies like the Joint Commission come in and they ask you about things like this, you can always reply with, oh, I can't remember off the top of my head, but whenever I do it, I look here. So as long as you know where to find your information, you will be okay. And that's something that you will go over on your new hire orientation. Always ask about policies and procedures. But first, the first step, we want to start cleaning the equipment before leaving the room. So we're going to talk about cleaning a bronchoscope right after we're done with the bronchoscopy procedure. So a bronchoscope, we can go down an endotracheal tube in through someone's mouth or nose and take the scope and put it into their lungs and take pictures and suction out secretions. We can take tissue samples. So the first step would be we're done with the bronchoscope. Our patient is stable. We're going to make sure we give them oxygen. But we, as RTs, are going to set up the bronchs and then take them down. So we clean the equipment before leaving the room. So we have what's called first step, and it is a package. It has a liquid chemical in it with a sponge inside, and you tear open a new one for every patient. And you wipe down the scope with that sponge, and then the bronch is hooked up to suction. So then you suck the remaining liquid through the bronchoscope, and that's going to start removing the microorganisms. And the big, if you have sputum, if you have blood, it's going to remove body fluids from it. And then you're going to put it in a bag so that we don't risk microorganisms getting bumped or sloughed off between the patient's room and then whatever area you clean. So we would take it from whatever the patient's room was, put it in the bag, go down to the respiratory department into our dirty room. A lot of respiratory departments will have a dirty equipment room and a clean equipment room. So you would go into the dirty equipment room and then you take it out and you would finish cleaning in the chemical or the Steris machine there. Physical sterilization is autoclaving. Temperature is going to be increased gradually under high pressure until 121 degrees Celsius is achieved. So this is going to happen in sterile processing. So if we had something in the patient's room that we needed to have physically sterilized. I think in our department, the only thing we ever used there was our CPAP humidifiers would go to sterilization. And you would take it from the patient's room after wiping it down with a wipe, take the rest of the equipment to the dirty room, and then physically walk up your equipment to be sterilized up to sterile processing. So what questions do you guys have for me on modes of transmission? What do you guys think about being out there as RTs and working around all of this? I see a couple faces going, oh, it's kind of scary, especially when we've learned about all of these different microorganisms.
I think just following the precautions is the most important part to keep yourself and your other patients safe.
Absolutely. Don't get lazy about it. Even if your preceptors, when your students say, oh, you don't have to wear gloves. If you're not comfortable, you can say, oh, thank you, but I just feel more comfortable, or for peace of mind.
If you're somebody that tends to be asymptomatic with things, should you take extra precautions knowing that, so that you don't unknowingly expose a patient?
That's a good question. I would just say, as long as you keep up the precautions and good hand hygiene, you'll be okay.
It cracks me up because you were saying like just wear your gloves and stuff. And I know the nurse manager at my job, there's a guy's genitals that were bleeding.
Oh.
And she was just holding it with like her bare hands and was like, give me paper towels. And we were just laughing at her.
Oh no. You brought up a great point though. You're going to want to run in, especially in emergent situations, and help your patients as fast as you can. Don't skip PPE. You can take that 30 seconds, and then especially for like codes, you want to make sure you have your gloves on. Take those extra few seconds to protect yourself, because you're not going to be able to help other patients if you're sick. What other thoughts do you have? Okay, so your bug project is due on Friday. So you'll have plenty of time to work on that. Let me know if you have any questions. Remember, it's got to be uploaded as a PowerPoint file. That way I can download it. You won't see the speaker notes when you see the preview, but I download it and the PowerPoint will pull up so I can read your speaker notes.
Speaker notes are just what you have on the slides, right?
Yep.
Okay.
Well, below the slide. So if you're in here, let me show you. Let me share my screen again.
Is it like you're in text citing, stuff like that?
So down here. So you just would click here to add notes, and then you just write your notes here. Because on PowerPoints, we want to have like short bullet points, maybe one sentence. We don't want to have, we don't want our slides to be overcrowded with information.
Oh, so we just elaborate more in the notes?
Yeah, just elaborate more in the notes. Perfect.
Okay.
And then you put your in-text citations here.
In the speaker notes?
Yeah.
Okay, cool. And I was going to ask, I picked Streptococcus for one of mine. And I was doing like research on it. Can I kind of stick to like strep throat, or do I need to like go in depth on like impetigo and stuff like that? Because I found like it was a lot more involved with that virus than just strep throat.
You can it could go either way for you if you want to focus just on strep throat, but if you want to focus on the other pathogens that are more severe, you can do that as well.
So either one?
Either one, yep,
okay.
Would be fine.
Thank you.
Because a lot of those bacteria have more than one pathogen that they cause.
And we also have one of our bugs be one that we've talked about, but isn't on your list.
Yeah, that's fine. It's a long list, so that's kind of just a jumping off point.
And when we did our group project in anatomy and physiology, I have a MacBook Pro, and I don't have PowerPoint on here. I have Keynote, and I think I had some trouble when I was trying to download just the PowerPoint. It kept converting to Keynote. I can try and mess around with it some more, but when that would happen, it would like change my fonts and everything would get moved around.
If you want when you submit it, write that little note just to jog my memory, because then your formatting, I will understand why your formatting is different. Or try Google Slides. You can upload it onto Google Drive as Google Slides, and that'll, and then upload it from there.
Okay, then I could just email you the link then.
Yes.
Okay, cool, thanks.
Sounds good. All right, guys, we'll reach out with any questions you have. I'm going to continue to work on grading. And then I will see you Friday for Peabody stuff.
Stacy, what is the MRE covering today?
Just last class.
Oh, okay, cool.
Yep. Okay. And then exam 2 on Friday will just be mode of transmission, and then Friday's content. So viruses, fungi, protozoa.
Is that one will be taken on our own or
Yeah.
Okay.
You'll take it on your own.
Do you have any more Quizlets for like what we did on Friday and like
I can
today?
make one.
Okay.
I'll make a Quizlet. Yeah.
All right. Thank you.
All right. We'll see you guys later.
All right. Bye.